So we have our next speaker, Eric Goodman, coming up. Dr. Eric Goodman, to be formal. So this is a talk I've been looking forward to all day. I have personally trained with Eric, and I know how good what he teaches is. That's why we got him on here. So this is something I'm really excited about. Eric has developed foundation training in decompression breathing principles. He's a doctor of chiropractic and he's a teacher. And I'm going to read you a little bit about Eric. So after dedicating years of his life and all of his money to learn how the body worked, Dr. Eric Goodman was well educated, yet stuck in daily pain with a diagnosis of severe degenerative joint disease at the spine. Sympathetic doctors told him the only way possible to relieve this pain was to undergo a painful back surgery, legitimate fusion of his lowest spine. But Dr. Goodman said no to surgery, one of the best decisions he has ever made. Foundation training's birth was due to his belief that corrective movement could be the answer to his pain and giving back his mobility, health, and life. It's been over a decade since that decision, and in that time, tens of thousands of people have found similar pain relief and healing through foundation training. He spent years studying human physiology and movement. He has trained world-class athletes for better performance and has healed people of all ages and occupations with lifelong debilitating pain. His theory of self-healing is now available to everyone. His practical program trains the posterior muscle chain, shoulders, back, butt, and legs, shifting the burden of support away from the joints and putting it back where it belongs, into the large muscle groups. All right, Eric, I'm really excited about this. I've personally had massive joy from your work, and I've used it with so many clients, and it really works. This is a fantastic way to take care of your body. So I hope you guys enjoy.
Thank you very much. I really appreciate that thorough introduction and a little bit of a background on the work. So thanks for that. That lets me actually just dive right into being effective with you all, which is what I'm here for. I don't think you need very much of my personal background story. What you need is the idea of how to help yourselves become a little bit more stable, a little bit stronger, a little bit better in general. And it's a very empowering process to do that. And my process of doing that, the thing that I've been refining now I'm 39 now, and I've been doing it since I was 27, is foundation training. And that's my recipe. That's my protocol. That's my baby. So I'm very, very excited to introduce you to the principles and the ideas, and I'll get right into it. We're in a world that challenges us physically in a very different way than we used to be challenged physically. We used to be quite literally very physically challenged in the sense that we had to move very often. We had to find our food. We had to typically chew a little bit more frequently, a little bit more aggressively when we were eating the food. We didn't have a steady, non-stop supply of groceries, and life was just in general a little bit more physically demanding. Now we're challenged physically in a very different way. We are less challenged physically. Our physical challenges manifest themselves into sort of physical symptoms that have a lot to do with decreases in stability, decreases in strength, and increases of symptoms. So what foundation training is looking to do, very, very simply, through your own movement and your own breathing patterns, is to increase your stability, increase your strength, and decrease your symptoms. You have much more power to do that than a doctor or a therapist coming at you and putting their hands on you and manipulating and working. Those are tools. Those are helpers. Those are accessories. They facilitate the body's natural mechanisms of healing. What they don't do is fix you forever. What you have to do is find something that you can actively develop the skill of fixing yourself with. Now, I would imagine a lot of people are going to speak about yoga and Pilates and everything down the line into things like Eldoa and Feldenkrais and the Egoscue method. And you might even have some kinesiologists in here that are going to talk from a very biomechanical standpoint. All of those are wonderful, and all of those will work if they're done well, number one. There is no do this instead of that in my lecture. I promise you that. What there is, though, is a couple small focus points. I'm going to teach it in a couple of exercises. If everything goes well, I'm going to teach you a nice clear-cut viewpoint of anatomy, and I'm going to teach you a couple of exercises that support that viewpoint and that perspective. And I say if everything goes well because we're on a technological schedule here, and we'll see how everything shares and how everything goes. But the general idea here of everything that I share with you is that I want you to increase your stability, increase your strength, and decrease your symptoms more or less on your own. Your body's weight, your body's center of mass, your body's ability to disperse a fall, or sometimes just dispersing its weight standing or sitting or running or walking or biking, that has a lot to do with the force dispersion of the muscles that surround the joints of your body. And I compartmentalize this into two areas. So does the whole world of biomechanics and anatomy, by the way, but I'm going to use their idea here and teach it very simply. The blue part of the skeleton in front of you is the axial skeleton, the central feature of the human body. It's the spine, the rib cage, the sacrum. It is not the shoulders. It is not the hips. It's not the feet. It's not the hands. It's the center of you that is more or less expandable upon breathing. And you expand that center of you with very specific pulleys. And I'm going to go into those muscular pulleys here very soon. And if you were to watch Sindra right now, you would see him going immediately into the breath that I've taught him over the years and that he's practiced many times, and he does a nice job. And you know, because you're seeing these front neck muscles not take over, but assist in a powerful rib cage, full rib cage, back of the rib cage in particular, breath. That expansion of the axis, the axial skeleton, the rib cage, the sternum, especially the back of the rib cage, especially the back of the rib cage. That expansion yields a little bit of power. It yields a larger connection point for the limbs, the appendicular skeleton, to pull into the body and connect to. A bigger platform yields a larger force dispersion, therefore smaller focal points of pressure, therefore fewer symptoms at those focal points. I promise it will make more sense as we go. Okay. This is what foundation training begins to look like. It's very tall. All right, so you'll notice in this first decompression position, in the split stance, you're going to see the feet are more or less angled straight ahead, and the knees are very minimally bent, almost like she's trying to use her hands and her head to lift her body's weight away from the ground, upward. Everything is upward in foundation training. You're fighting against gravity with as much surface area of your body as you can find. The center position, the founder, is a very conventional foundation training pose. It's more or less our namesake pose. It's one of the ones that I'm going to teach you today. And it allows you to integrate several muscle chains of the body into an isometric, powerful hip hinge. It supports the most fundamental range of motion in the body, the hip hinge. And then we challenge the respiration, the breathing within that isometric, which then challenges the other fundamental range of motion in the body, breathing, rib cage expansion. You'll notice the anchoring picture, and that anchoring process gives us a platform from which we can expand the axial skeleton to the best of our ability. So again, the axis is the spine and the rib cage for all intents and purposes. And we want the spine and the rib cage as long, wide, and deep as we can have them. To get there, we need the platform of the pelvis, where the spine lifts away from, where the feet kind of push away from. We need that platform to be stable and powerful. That anchoring, you'll notice those lines of convergence between the feet, and the feet are inwardly rotated ever so subtly. That position is very specific to foundation training, and it's very specific to an anchoring of the arches up to the groin, up to the pubic symphysis. And I'll get into that as we get a little deeper into the actual movements and anatomy. Our first and foremost principle is decompression, the action of taking the axial skeleton towards expansion. All right. If you read True to Form, which is the book that I put out a few years ago that gives the very specific theory of foundation training, you're going to read that the whole purpose of foundation training, the basic mission statement, is to re-educate the axial skeleton towards expansion. Because so much of our life compresses us and takes us forward and allows our body to change its otherwise healthy, somewhat powerful position. So we're going to have a lot of decompression exercises the first several weeks or months you learn foundation training. You're going to very actively work to pull the tightened, rigid tissue of the rib cage apart so that it can get stronger by getting a little bit longer first and then learning to contract a bit better from that healthier length. Decompression is a very anatomical process, and you have to understand the anatomy a little bit. You see all these muscles that surround the rib cage? Well, those are your inflation and expiration muscles, okay? Not all of them, but there's several of the very important ones. Those muscles act as levers to physically pull the rib cage apart to stimulate the diaphragm in its healthiest contraction, which is basically having the central rim, the bottom rim of the entire rib cage pulled apart by very powerful muscles that are deep and small, but positioned ideally for expansive power at the rib cage, the serratus muscles. I think I'm going to go into anatomy here just a bit. So you'll notice these two vectors of arrows here, the forces that we're looking to obtain from the muscle contraction that you see. All right? You'll notice the first part is a rib cage, the back of the rib cage, that is showing an outward lateral expansion. That is one of the hardest ways for a human to relearn breathing, but it's also probably the most important in modern era. The more we sit down against backrest, the more we let our head drift forward and our sternum droop down, it quite literally makes a good portion of the back of the rib cage, and therefore the expansion at the back of the lungs, relatively unavailable. Not turned off, not dead. You're not killing yourself, but you're also not creating an efficient breathing environment. You're not allowing your body to have one of the most effectively metabolic processes that it can possibly have, which is the rumination of powerful breathing, the 15 to 20,000 times you breathe a day. With foundation training, we're trying to make a small improvement at the mechanism of breathing, the biomechanics of breathing, so that when you're not paying attention to it, those small improvements yield good results. The anchor is what the decompression expands against. And to get into the anchor, I'm actually going to go into another app here, and I'm going to show you guys some actual anatomy. So this app is called Visible Body. I love this app. I hope everybody that is a fan of mechanics and movement and anatomy will go and take a minute to look this up. I think it's $25 for their app online, and they've always been very supportive of foundation training. So check out Visible Body, because you can do all sorts of cool stuff with this, like figuring out how the center of gravity supports itself and how to improve upon that with movement and with efficient muscle contraction. So you'll notice I'm going to click a couple muscles here, and they'll become blue. These central pulleys are the adductor group, the groin muscles, okay? That central pulley connects the inner femur, the thigh bone, right there, to the pubic symphysis, right there. Zoom in a little bit. So we've got this leg, and we've got that center, that blue piece. I'll make it white again for a second, and then blue so you know what I'm talking about. That center of the pelvic hemispheres where they come together, that is your center of gravity. When that is not able to maintain center or move accurately, your spine will naturally begin a little too much movement, particularly at the lower spine or way up top at the neck. That pubic symphysis needs to move like a girdle. It needs to glide like a gimbal almost with a camera, where it's keeping the top somewhat balanced by doing the vast majority of the movement for it. You have muscles under there that do a very good job of keeping the pelvis relatively squared as the hip joints go through their large circumferential range of motion. And the important ones that I want to talk about here, the positional muscles that allow the adductors to do their very, very important job of centralizing that pull on either side of the pubic symphysis, right here, iliacus muscle. The iliacus muscle is one that very few people talk about all that often, but it really does quite a lot. And when I say it does quite a lot, that's more when it's off of its better axis. When it's out of its effective contractile position, that muscle does a lot to throw off movement patterns. It allows the center of the body, the center of that gravity, the center of the pelvis to move externally a little bit too much. When this is dragged kind of tighter due to the external rotation of this, the hip joint, when that tightens because of tight glutes, maybe tight lateral hamstrings, maybe a tight IT band, when that tissue tightens, it throws that gigantic pull of the adductor off. Look at the size of this muscle. These are your center. These are more or less the strongest muscles in your body, but they don't have a very drastic pull. They kind of just pull up and in towards the pubic symphysis. And again, when these are too tight, the butt muscles, they pull these too long. They pull them off of their central axis, and they make you walk like a duck instead of like a human. They make your feet turn out. They make your tail tuck very often. They make your rib cage collapse a little bit. And the iliacus muscle, when it's out of its effective contraction, will almost always allow the psoas muscle to do what it does when it tightens, which is lock up the lower back a little bit. Keep the ribs a little bit too close to the pelvis. Keep the pelvis a little bit too in between the femur and the rib cage where it attaches. There's nothing there up the rib cage. It's fine. So a little understanding of where the anchoring idea comes from is we have to stabilize the front wings of the pelvis. Iliacus, where it inserts into the femur, and the psoas that follow along and inserts in the same spot at the femur. Those muscles are very, very much in control of the ability of the pelvic wing to stay accurately internally, not rotated, but contracted, just a little bit of a central tone that is furthered by the transversus abdominis. So I'm going to go into the transversus abdominis for a minute. Give me a second while I switch views here. So we've talked about that central pull of anchoring to the bottom of the pelvis. One of the big reasons for that is so that this muscle, the deepest of the abdomen, sort of the tone setter for the entire torso, this transversus abdominis that contracts not to the center of the abdomen like a corset being tied together, but away from the back of the rib cage. You see where it kind of touches this floating rib here and this rib here? When that transversus abdominis is contracting well, it is allowing the back of the rib cage, the back ribs, traction with width to get wider and wider and wider as the front of the abdomen stays long. See all this? All the white part versus the red? That white doesn't contract. There's nothing, no contractibility there whatsoever. It's like dense tissue. The red pulls that and the rib cage together like an oblique helper. But the obliques are very powerful in their side contraction, flank contraction. The transversus abdominis is just a tone setter. It establishes tight length at the abdomen so that the rectus abdominis can activate better, so that your planking muscles can activate a little bit better, so that your lat muscles that wrap the outer back of the rib cage can wrap better. And basically that transversus abdominis reacts definitively to those muscles I was just talking about, the iliacus, the psoas, the adductors, and the anchoring muscles. One of the things that I know a student is understanding foundation training when they display very specific thing to me. They understand that there is a direct connection of the sternocleidomastoid muscle, the transversus abdominis, and the adductors, and they can feel that central line as they stabilize the neck more and more and more. They feel the legs pulling at each other under a contraction of the adductors, and that's kind of a level 2. That's like you've been practicing FT for a while. That's that moment of stability that you then move past and progress from, usually after 3 to 6 months of practicing the work pretty thoroughly. So I'm going to go back to the rest of the presentation for just a second. And let's see. I am not the best. Okay. I'm imagining everybody can see the FT anchoring foot position and pull. Sindra, do you mind giving me a little nod if you can see that? Okay, thank you. So anchoring is a process that starts at your feet. And the whole idea of where your feet are there is they're kind of pulling up. They're pressing into the ground very firmly at 3 specific points of contact that I've been teaching for almost 10 years now, which is a tripod, the ball joint of the big toe, the ball joint of the pinky toe, and the heel. Like you're spreading your foot out away from the heel as it grabs into the ground, or as those joints press into the ground and the toes lift away from it, like that. That's fine too. But that pressure downward very quickly transfers into an inward or an outward isometric squeeze. And that squeeze happens at the hip joints, transferring force through the feet. The hips begin the movement and the feet transfer it to the ground. What it feels like is that the entire leg, or a very good portion of the leg, is just there for you. It's powerful. The weight of your torso is transferred into the muscles of the leg and you feel strong, like you're in an athletic stance. The deeper you go into a hip hinge or a founder or one of our woodpecker exercises or any of our varied hip hinge exercises, the tighter that anchor will become and the harder you'll be working with it. So I'm going to go back to the anatomy for a moment, and I'm going to talk a little bit about how that whole body comes together. And we get this idea of integration. Integration is a very, very, very simple thought process. The better you get at contracting the proximal muscles around the hips, around the torso, the better you're going to get at working with the distal muscles down the limbs, the appendicular skeleton, the shoulders, the legs, the knees, the ankles, the hands. The stronger the center gets, the more connected and integrated movement becomes. So with foundation training, we are looking at center first, and then we are looking at coordination, strength, and stability coming from there at the limbs. What my model in this picture here, Gail, is doing is she's showing a very basic foundation training squat that simply adds a little bit of supination at the shoulders and wrists, a little bit of a hip dominant motion, taking the weight back as you drop down, and the chin staying retracted and tall as the spine stays strong and wide, and the hips and legs do the heavy lifting for the entire motion. That's what integration feels like, is it's accurate motion. It's nothing special, it's just accurate. So the founder, I'm going to try something after this. I have my streaming site up, and I have a couple videos that I want to see if I think I can play them for you. I'm going to try to so that you can actually learn real time with this. But the founder is our posterior chain integration exercise. The model in this image is Jesse. He's our primary coach. He coaches all around the world, teaches with me all around the world, and sees pretty much every patient I've seen for the past 7 years, a long time now. But what he's doing is he's making sure that his body is powerful. He's breathing himself as big as he possibly can. You'll notice the first position, he has a very specific arm position. His elbows are pulled wide. His chest is big. His back of his ribs are big. His head isn't looking forward or down or up. It's just pulled back and strong. He slowly begins to draw the hips back, and then there's a counterbalance with the arms coming forward. And then the finished pose is that isometric that you see in pose 3. But let me get to this video and see if I can help that make a little bit more sense. This might take a second. You know what? I'm going to go back to anatomy instead of wasting your time trying to figure this thing out. Seems like a much better use. The exercise that I was going to show you, the founder video, all of those videos, number one, you can easily learn foundation training on YouTube. You can learn a good portion of our basic stuff for free on our YouTube channel. And if you want to get a little bit deeper in it, we have a streaming app, and that has very, very thorough, very involved programs that teach all these exercises and numerous workouts in detail. But let's focus on anatomy while I've got the anatomy up. A few of the key elements that make the body somewhat unavailable for very healthy movement happen at the muscles that you see ahead of you. And I'm going to talk about the pec minor for a second. And then from the pec minor, I'm going to talk about the shoulder blades and the lats. So the pec minor is not a muscle that's very strong necessarily. It's not strong enough to just pull your shoulders up and over your body and shorten itself and create havoc at the back of the ribs and create havoc at the neck muscles and all of these different pains and shoulder pains. But if you wear your shoulders kind of forward and down long enough, often enough, that pec minor, if you look at your phone often enough with your head down, if you read books in front of you often enough with your shoulders forward, that pec minor is going to adaptively shorten. It's going to become a less available contraction, a far less available overall helper in the system. And it's going to pull the shoulder blade kind of up and over, and maybe not pull it there, but it's going to not let it depress back down. That's what the pec minor does. When it tightens up, it pulls the shoulder blade over, and when it's just too tight, that shoulder blade stays up, your neck stays tight, your traps stay dominant, your lats are not utilized enough. In order for the lat muscles, powerhouses on the back of the body here, the latissimus, in order for those muscles to fire appropriately, that shoulder blade, it doesn't really want to be up and over them. It wants to be almost pulled, not into them, but in front of them almost. You can't pull it in front of them. It's not going to get there. But it's as if you're trying to pull it in front of you. That shoulder blade, when it's pulled up and over, takes the lat out of an effective contraction, and that lat muscle is a major stabilizer of everything from the shoulders and the neck to the lower back and the pelvis. You need your lat muscles functioning well to have a long athletic career and to have a long pain relieving career. To get the lat functioning well, you don't just stretch and relax and push on the tissue of the pec minor. You don't just let the body stay in its adaptive positions and expect everything to go away and change. What you do is you create that decompressed rib cage platform, and you teach the body that it's not designed for position here. It's designed for a long platform, a broad platform, and that the rib cage is not a rigid brick. It's a platform that supports the vast majority of the torso, including the shoulders, including the clavicles, including the neck. And when that rib cage is in a healthy position, the pec minor is in a healthy position. So we fix the pec minor, the tightness, the intensity. We fix that by very, very simply breathing the platform underneath it broader, wider, and more accurate. We collectively involve all of the muscles that surround the rib cage, including the lats, in our breaths, and suddenly the pec minor begins to release, and it learns to live in a much healthier place. That is the basis of all of foundation training poses, is not to fix one simple thing, but to make the body work so effectively and efficiently that symptoms allow themselves to release and to relax. And in doing that, you get the body to change. You get the patterns to change. One of the big things I work on is hamstring tension. I want to show you just a little bit of the hamstrings because a lot of people do not understand what hamstrings look like, how they interact, how they contract, or anything like that. The hamstrings are several muscles. And what I want you to understand is that they connect your butt right here at the lower edge of the pelvis, right along there at the ischium. They don't connect at your knee joint, okay? They connect below your knee joint. That's a very important piece of the hamstrings, the medial and the lateral, is that they go beyond the knee. So if you're a hamstring stretcher and you don't bend your knees a little bit, you're kind of putting your hamstrings in a position that can't stretch them very well. You're going to be feeling that stretch in one of two places, either where it inserts at your butt or where it inserts kind of right behind the knee. You're going to feel that stretch of the non-elastic tissue of the hamstrings where it becomes a tendon and rolls into your joint there. The adductors do insert above the knee. those deep muscles do control the knee joint in a very different way, and they do insert above the knee. In fact, the adductors being in a very healthy position facilitates a substantially better hamstring contraction. So you'll notice that a lot of the corrections that we make in foundation training have to do with internal rotation of the pelvic wing, just a subtle 3 to 5 degree internal rotation of the pelvis. Well, we do that so we can access more of these. We do that so that the hamstring muscles are no longer turned out away from due to the learned patterns of external rotation, of twisted out hip joints. Those learned patterns, under a little bit of strength and a little bit of practice, are so excited to fix themselves. They can't wait to improve themselves. They want a better pathway. Your nerves want a healthier pathway. Your sacrum wants a healthier pathway. And I never tell people internally rotate your hips all the time, but when you're doing corrective exercises like foundation training, one of the most valuable things you can do is make those small positional changes that allow your hips to really function well. I'll rotate my computer out of the second a little bit. These are the costs of doing things outside of nice weather. I'll take it. So you've got your lat, got your pelvis kind of in the center, got your hamstring pulleys at the back, and then you've got these, and I'm going to start clicking a few muscles right behind the butt, the deep external rotation muscles. These are what I would consider premier accidental culprits of pain. These muscles get sat on too often, and the big, powerful butt muscles that sit on top of them, they're big and strong, but they're kind of dumb. You got to understand that they're kind of dumb. They are going to listen to what those small muscles tell them. Your glute max is literally under the control of these itty bitty small muscles because they set the tone for the larger contraction of the hip complex. The glutes have a big part of that. When these external rotators are sat upon too often and your hip joints just kind of slowly drift apart, you cross one leg or the other, your toes face out, your back slumps, your head comes forward, you're looking at your screen. Those positions have very, very, very specific and expected biomechanical breakdowns. And they occur initially here and at the pec minor area where I showed you earlier. It's where the hips collapse and it's where the shoulders drop. Those areas have almost everything to do with your glute amnesia, your sciatica, a lot of your degenerative joint disease, a lot of your degenerative disc disease, a lot of your lateral and medial knee pain, a lot of your plantar fasciitis and shin splints and heel spurs, a lot of your generalized lower back pain, and a lot of your generalized neck pain and shoulder pain, oddly enough. Because, like it or not, the human body is a very, very, very web-like organism. And our tissue is just intertwined, and it moves, and it pumps, and it's hydrated, and it's filtered, and it's there's all sorts of things that are happening. And all of that is moving as well, and we have somehow this stable structure that moves. And if you let it go a little bit unstable, it's going to happen kind of quickly. And what I've learned now in a decade of teaching people to kind of take over their own stability, external rotation cannot be your guiding movement pattern in our modern world with hip joints. You can't allow your hip joints just to continuously keep turning out if you have an office job, if you drive a car very often, if you ride a bike very often, any of those types of things that are very different, by the way. But if you do any of those things, your hips are naturally trying to adapt to the positions that you're getting used to. And the more, I'll take my phone here for a second, the more you look at a phone and kind of let your head drop and then you look up a little bit to try to find it, or you're looking down like this, those changes in the neck position, they are also drastically felt and drastically impactful at these smaller muscles of the pelvis, even at the pelvic bowl here, even at the pelvic diaphragm. You know, you have to think of your torso as a very fillable, expandable tissue. Many people in this lecture have heard the idea of tensegrity. Well, that's tensegrity in the human body, is expansion yielding better stability than contraction and compression. So I want everybody to think of the torso as the area where you can make that expansion. And the bigger you get, the broader you get, the bigger you get the back of the ribs in particular, the less likely you're going to experience the things I'm talking about here, because you're quite literally doing the opposite of sitting on your butt. You're pulling the torso away from that same compression, decompressing the rib cage, the torso, the abdomen, the lungs, the neck. Each of those pieces assists the subtle decompression along the spine, the thoracolumbar fascia, all of those areas. Right. The woodpecker is another version of a posterior chain exercise. You'll see in the founder, 2 legs doing the same thing, and the woodpecker, 1 leg doing the same thing as the founder. 1 leg in the back acting for stability and almost like a rudder, just making sure that the body is stable. But notice, I know I can't click on these images in this presentation, but in image 1, the knee position looks the same as image 2, as image 3, as image 4, but her torso changes pretty radically. That is the effect of leveraging the posterior chain accurately in what's called an eccentric contraction. Gail's hamstrings in this position are going from a shortened position to a increasingly long position, and at the same time they're absorbing the weight of her torso in an increasing absorption as it goes further and further away from her center of gravity at her hips. So the hamstrings, the butt muscles, the calf muscles, the foot muscles, they're all working against the weight of her torso, and the further it moves, the heavier it gets. That is probably the best way I have ever found or seen to train the coordination and strength of the posterior chain, unilaterally and bilaterally, but in the same position where you're teaching it to absorb force instead of teaching it to just pick up force. Now, in the chronic pain world, it's very easy to get people to understand the significance of body weight movement. But I also work in the training world a lot. I also work in the competitive sports world a lot, sometimes with some really high-level athletes, and I can't take them away from weightlifting, so I have to integrate the ideas that I have in body weight performance into their training without harming their weightlifting. And initially, I was a little nervous of that for a couple of years, but time and time again with various teams and various athletes, I saw that the more we focused on the neurology of movement, patterning, and particularly the absorption of force before the generation of force, oh man, did they get stronger. I mean, we were doing primarily body weight work, but their lifts went up because their mechanics improved and their recruitment improved. And that's the basis of these poses, is recruit as much tissue as possible to support the body the absolute best way that you can. This is my spine. I do not have a healthy back. I have healthy back muscles, and I have healthy nerves at this point, but I don't have a very healthy spinal column. My lower spine in particular is just beat up from years and years of training, water polo, weightlifting, sitting in school, getting graduate degree, all of it. And this is why foundation training has to work, is I refuse to get surgery at this stage of my life, and have refused now for 12 years. And I include this spine in a handful of presentations I give, including our certification presentations, because I want people to understand I didn't come up with this. I learned this along the way as I forcefully and aggressively made my spine stop hurting. And what was kind of revealed to me over the years and years and years of practice was that I had to forcefully reinitiate curvatures into my spine, not with flexion and extension, but with length and expansion. And the better I got at length and expansion, and then supporting that length and expansion from the ground up and from the top down, the less I ever felt the symptoms that a spine like this would otherwise give me, which really, really hurt when they go bad. I mean, really hurt when they get bad. They stop me from being a happy human being for many times in my life. And I always try to give people the hope that I feel from these exercises, which is that I promise you can keep getting yourself out of pain. You may never be pain-free, for years and years and years at a time. I promise that you can keep getting yourself out of pain if you develop the skill set and really take it serious. I'm going to stick around and chat a little bit more, but I'm just going to put this on there if you want to learn about foundation training, if you want to go a little bit deeper. These are the websites that we typically use. If you Google foundation training, if you put it in YouTube, you're going to find free videos, and I hope you use them. Give it a try. We're a small organization that is starting to get a pretty substantial reach and network in the corrective exercise, performance, and biomechanics community. I call myself a chronic pain generalist because generally I work with chronic pain patients of all different types, from quadriplegics and stroke victims to people that just have a bad back and they're sick of it. But I do also get the chance to work with some really interesting athletes and some really gifted athletes. And I love the correlation that the thing that gets people out of pain is also the same thing that gets them to accelerate their performance substantially. And I'm very proud of that. I hope people take me seriously and at least try the free stuff. And if you try it, don't try it once. Do it for a week or two. Do it for 3 weeks. See what you feel like doing foundation training for a handful of days in a row. You'll notice why people start to talk about it and why I very proudly and excitedly talk about it. I've been doing the same thing, trying to figure out the exact same poses now since I was 27. And again, I'm turning 40 this year. And I hope I'm doing this for the next 40, 50 years easily. I hope everybody that learns our work gets at least what they want, if not more, out of it. Check out our streaming site if you want a very detailed program. But other than that, I'm going to take a look and see if there's any chat questions on here, if that's all right with you all. Now you should see me. Can you see me? I see Cinder.
Yeah, we can see you, man.
Okay, great. Sorry, it took me a second to figure that out. Okay. Going to read a couple quick comments here. I do have some experience coaching dancers. I've worked with a number of dancers. Dancers are taught to point. Pilates is a great tool for dancers if they want to get very strong at a lot of the muscles that make dancers already strong. Pilates is a wonderful tool. Dancing is a wonderful tool. And I will promise you that both of them improve just a little bit with some foundation training. Okay? When you're breathing during decompression exercises, the decompression breath is a rib cage fill. And I have a free tutorial on YouTube called Decompression Breathing. So feel free to go and check that out. And it'll probably be more detailed than what I give you right now. And I'll be working with a model that you can see. Decompression breathing is an expansion of the contraction of the inhalation muscles that makes the ribs expand. And the exhale is where the abdomen tightens. You're creating as much upward length during the inhale as possible. And then as you exhale, you're using the abdomen. Think of that transversus abdominis. I'll show you again real quick right here. That transversus abdominis allows the body to sort of wrap. This is a little bit too superficial right here. But a very big portion of the decompression breath is the exhale, and the vast majority of the exhale is done right here at the transversus abdominis. You're trying to find the longest, deepest tissue of the abdomen to force the air out. And what that allows you to do is keep the rib cage as big as possible. You're doing your best to breathe into the rib cage, creating space. And as you exhale, this is the frustrating part of decompression breathing. As you exhale, you're keeping it. You're keeping all that space in the ribs you possibly can, and you're tightening the abdomen to force the air out. And that is how we eccentrically teach the muscles of inhalation and exhalation to operate a little bit stronger, a little bit more powerfully when we're not paying attention to it. I am based, for those asking where I'm based on here, I'm based in California, but my team and I have taught 1,100 instructors around the world. We have extraordinarily talented instructors, and then we've got decent instructors. I hope you find the extraordinarily talented ones, but even the decent ones will be able to help you. I found that over many, many years. We have instructors in over 30 countries, and I hope you take the opportunity. If If you're really serious about learning this, there's nothing like learning from somebody in person. I promise you that. What about the diaphragm? The diaphragm is the beneficiary of foundation training. All of that anatomy talk I gave about the expansion of the rib cage, the serratus muscles pulling the ribs apart, the rationale that we have to get the back of the ribs to expand as much as the front of the ribs, all of that is geared at one thing, making the diaphragm naturally go from here, as you inhale, to here, as you exhale, to here. Diaphragm does, and it does it as a direct result of the expansion of the perimeter of the bottom rib cage. Perimeter is all the way around. It's becoming very, very popular to talk about a 360-degree breath. Beautiful. I hope everybody learns it and benefits from it for as long as possible. This is a long question. Bear with me for about 10 seconds while I read it. Do not burn your anatomy books. The person who's a sports therapist and has a spinal cord injury 10 years ago. Sorry you got the wrong diagnosis. That happens very often. The spine is a very, very awkward series of electrical energy, and it can manifest that electrical energy into any series of translations that we call symptoms. Sorry that you had that misdiagnosis. And all I'm going to say is locus of control is what comes to mind here. And a locus of control can be one of two things. It can be, this is what happened to me, and that's what it is, and I'm a victim to that, and my locus of control is outside of me. Or it can be, this is what happened, but I'm going to study my ass off. I'm going to develop my skill set. I'm going to take the time and the frustration as fuel, and I'm going to improve upon my ability. And I hope that you do that. I speak from experience in saying I truly, truly, truly hope that you get to the other side of your injury. And don't lose your curiosity. Don't get angry at knowledge. Find more. It's available. It's out there. I'm going to answer two more quick questions on here. One is on fibromyalgia, which is actually a really important thing to talk about, because fibromyalgia is a overwhelming series of symptoms in the body that can very, very easily lead to frustrations, to depression, to all different things. First and foremost, before anything else, nutrition. Are you eating processed foods? If so, stop that right now. If you haven't stopped that, or if you've already stopped it, or if you're already really dialing in your nutrition well, great. Start looking at saunas. You got to sweat a lot. Start looking at things like B12s, different things like that. Things like L-theanines can help. Much more important than any of that is get yourself into nature. Bare feet, wet, moist earth in the ocean or in a lake or in a river if you have it nearby. Do it every single day, like an absolute have to do it, like a prescriptive medicine. Start looking at the sunshine in the very, very early morning a little bit more. Start going to bed a little bit earlier in the evening. Turn off as much technology as you can. Fibromyalgia is a wave. That wave will crest. That wave will crest and deepen and intensify your symptoms. The worse you eat, the less natural your life is, the less healthy your relationships are. Those stressors are what yield the symptoms of chronic fatigue, chronic fibromyalgia, and all of different things like that. So I hope that you look very deep into the overall human and the environment that your body is in and the things that you're feeding yourself before looking at any individual thing that will help you with fibromyalgia. That goes for everybody with chronic symptoms. The last one I'll do is with diastasis recti. This is a question that is asked so frequently of so many different therapists, and it's a very challenging one. And I'm actually going to go back to the anatomy for a minute, answer it. Diastasis recti is a pubic symphysis issue. It is a pelvic issue most often, and it is a back of the rib cage issue most often. So before I even go to it, I want you to think of how I described the transversus abdominis to you. Back of the rib cage and pubic symphysis. The deepest layer of the abdomen that establishes the tone for the rest of the abdomen. And that's what this guy is. Now this right here, the pubic symphysis, that's not a very strong, I mean, it's strong, but it's not that strong. it's movable, it's pliable, it's a very dense connective tissue, but it's not bone. What it does is it connects the bones. Okay, you can go underneath here and really look. All right, in diastasis recti, this thing ain't working all that well. There's separation that occurs, but that separation typically occurs because this and this begin to be pulled away from each other. Like the back of the body is closing and the front of the body is opening. And that wedges the pubic symphysis, where the front of it gets wider and the back of it gets narrower. And that establishes a very unfortunate tone for the muscles that connect to the pelvis, the ligaments, and much more importantly, because what is felt here will transfer up to the wing at the top. Think of the very top of this bone I just clicked on. That's going to externally rotate and open even further than the wedging that occurs here. And diastasis recti has to be fixed below the pelvis and above the lower back. So we're going to go here. If you see the floating rib, the back ribs there where I'm clicking, these vertebrae, the thoracic vertebra, particularly the lower edges of the rib cage, those last 5 or 4 thoracic vertebra, you got to lift those up and back to fix a diastasis recti. And at the same time, you have to converge your adductors. You have to allow your adductors, your groin muscles, your anchoring muscles to do what they do, which is pull towards center. This is my diastasis recti image. This is an anatomy image that I use in courses to teach how diastasis recti is remedied. And it's remedied. Pay attention to this, please, and practice. This is all available on my baseline program. All of my decompression exercises do exactly what I'm saying right now. They stabilize the sternocleidomastoid muscle at the top of the neck here. They stabilize the psoas and the iliacus muscle at the center of the pelvis. And in doing that, they centralize the groin tissue and the hip tissue. They pull everything towards the center of that pubic symphysis so that the muscles that connect around the spine, the transversus abdominis, the larger abdominal muscles, the other back muscles, the spinalis muscles, the extensors, all these different things can find a healthier contraction. And if you're trying to fight diastasis recti, stop doing things from the pelvis up and start contracting things accurately from the pelvis down, and it will be your best bet to get there. Okay? So without further ado, I could go on with questions like this forever, but it's really not the time or place, and I don't really see, when I see patients in person, I love doing this, but words on a screen are not the best way to understand a symptom or a patient history. So thank you all very much for hearing me out about foundation training. This is my life's work. I will teach it for the rest of my life. It means so much to me that people are learning it and enjoying it. Sindra, Steve, thank you guys for inviting me. And I hope everybody that watches this gets a lot out of it. Our website is foundationtraining.com. Our work is called Foundation Training. Our books are called Foundation. Our app is called Foundation Training. We have instructors all around the world that I would love it if you support them. We get nothing from you guys supporting our instructors except knowing that good information is getting out there and we are helping the careers of others. If you want to support us, that's our streaming site. And if you just want to support yourself, you're welcome to go to YouTube and learn for free. I got no problem with that at all. So I put stuff there. So without further ado, guys.
Thank you so much, Dr. Eric, for coming on.
My pleasure.
Wonderful as always.
Thank you, sir.
I want to share a really, or do you have like a final one-liner you want to say? You kind of rounded off.
You're doing great. You're doing great. I'm done.
I want to share like a quick, like what I experienced. So, hey everybody. Had an hour of downtime and still feeling quite zoomed out, but here for our next presenter, Neil Pearson, which is someone I'm looking forward to hear speaking. And this guy is called Captain Hope, which I think is a fantastic nickname. He's a physiotherapist, yoga therapist, author, and clinical assistant professor. And he is incredibly qualified. He has received awards, including Excellence in Interprofessional Pain Education from the Canada Pain Society in 2012. He's an aspiring writer, an engaging educator, and compassionate clinician. Neil is able to make the complex understandable. He's willing to share his knowledge and expertise in pain care and always ready to learn more. So he's going to be talking to us about embodied pain education. So Neil, the floor is yours. I'm really excited to hear what you have to say.
Great. Thanks, Cinder, and thanks to both you and Steve and everyone for inviting me here. It's really is a pleasure. So I'm in beautiful British Columbia, Canada, where it's really rainy right now. It sounds like it's raining where Steve is too. And what I wanted to talk about was, as you heard, was about embodied pain education. And so it was really wonderful on the panel just a while ago to hear really this focus on the importance of pain education. And so I want to talk to you a little bit about the pain education piece, but then more talk about how we can make the education more embodied. Now, Cinder, can I share screen? That'll work. I'm guessing that's a yes, and you can see my screen now.
Perfect.
All right. Okay. So I'm going to go in and out from using this, but I thought it would just be give you something a little bit to look at. So that's who I am, and we're going to talk about embodied pain education here today. So I'm going to jump right to the ending, right from the beginning, and just mention that sort of main thesis that I have to present to you is this idea that really when we educate healthcare professionals, or when we are educating people in pain about pain, we usually take a more cognitive kind of approach than a contemplative or embodied approach. And what I'd like us to consider is this idea that the practices that we do, like the practice you've been doing with all the speakers here, or if you do Tai Chi or you do yoga or other contemplative movement practices, they are actually educational agents. We just don't think about them a whole lot like that. But within these practices, and I'll focus on yoga because that's something that I have been teaching for a long time, is this idea that the techniques or the practices that we go through provide us with repeated experiences that are inconsistent with our understanding of the slow pain care. So this becomes important that sometimes people will what you'll find is that someone will tell you something new, and it doesn't quite match your worldview. It's like your worldview is this. This is how I see the world. And somebody comes along and tells you something new, but it doesn't really match in with what's there. So we can just park that new idea as an outlier.
Sorry, can I jump in? Your sound is slightly jumpy. I'm not quite sure what's up. Maybe because it's rainy or something. It's skipping slightly. Do you know if there's anything you can go slightly closer to your microphone or perhaps Wi-Fi or something like that?
Yeah, and actually it's really hard to hear you right now. So sorry about this, everyone. So is it any better right now with the sharing? No?
I mean, I can make it out. I don't think some people can. I mean, if not, I guess we just, if there's nothing to do, I think we just have to continue-ish.
Let's just try a couple of different things here.
Okay, can you hear me okay now, Steve?
Perfect, it was that thing.
Okay, all right. If that works better, then let's do this. Sorry about that, everyone. All right, so sometimes we in life, someone comes along and tells us something that makes sense. And but then when we consider it, we see it doesn't really fit with our worldview. And so we just sort of park that idea out there and don't really consider whether it's true. But you can imagine if you kept on hearing that message a number of times, sometimes what happens as that happens, with the repeated experiences, is that you start to wonder about, well, maybe the way I saw the world isn't quite the way the world really is.
And so those repeated exposure to information can sometimes create what we call cognitive dissonance that allows us to start to wonder about how we could take this new idea and bring it into the way we see the world and the way it is. And this can happen around pain. The same kind of thing, though, can happen with other experiences, like movement experiences. So as an example, say you come to see me, you have neck pain, and I'm a physical therapist, and I do some of those, manual therapy things on your neck. And at the end of doing that, you say that you can, you show me that you can move and it hurts less to do that. And so this is actually something that we want to consider as an educational moment or an experience, because what you just experienced is possibly different from what you sort of saw. Your previous experience might have been that this pain really isn't changeable. There's not really anything that can be done about this. But now you've just had an experience that's inconsistent with your previous experiences or your previous belief that pain wasn't really changeable. And so when we do a contemplative practice, that same sort of thing happens. When we do awareness practices or mindfulness techniques or meditation techniques or movement techniques, a lot of times what's happening is that we're experiencing something that is inconsistent with what we thought was really happening. And that those repeated experiences can sometimes make it more real. And I think that's another really important thing, is that what we're talking about here, although we're talking about embodied education, I guess the first thing I want to say is that cognitive education, or the education where we learn something new from verbal or written information, it's not that it's not embodied, but somehow it's different. Right? There's a different experience when we do something with ourselves, when we learn something from doing, for most of us, than when we learn from just acquiring new information. So I'm going to go back and share my screen just a little bit. So I want to make sure I get some key points here. Before we're going to move into a few little practices as we're going along here. So covered that. So I'm not sure how many of you have understood about pain education or learned about it, but really from the late 1990s and then really in the early 2000s, there were some, especially some physiotherapy researchers, Lorimer Moseley and David Butler, who created this book called Explain Pain and did a lot of research showing that when we teach people about how the pain systems work, when we teach people that pain is complex and that pain is like perception and pain is a protective mechanism, and we start to teach people about different ways of seeing pain and understanding pain, is that what happens is people start to reconceptualize the pain or see pain as something different than they thought before. And the research is really, really clear that when we do this, what it actually does is it allows people to, at the end of just getting this education, that a lot of people at the end of the education would have less pain, be able to move with more ease, and actually would report that their quality of life was improved from this new knowledge. And it's important to understand around the pain education that we do with people that it's a bit of a different kind of education, because everybody already knows about pain. Everyone's already experienced pain, or I shouldn't say everyone, but the vast majority of people have had pain in multiple different ways in their life. And so when we're teaching people about pain, we're not teaching to a blank slate. We're teaching to a person who already has beliefs and opinions about the pain. Don't worry, I'll get the slides back again for you. I see somebody asked for that. So, so what we want to do is, with this pain education, is to teach people to think about what they think about pain in new ways. So, and I think this is really important, that we normally don't take time to think about our experiences of pain. Most of the time we go through life with this idea that pain totally equals tissue damage. That's what it's for. And if you ask most people, what's the purpose of pain? I think the majority of people will say, well, the purpose of pain is to tell you you've been injured. And of course, we have to say that's true, but it's just not complete. It's not complete and precise. Pain's far more complex than that. And if we did come up with a one-word answer to the question of what's the purpose of pain, usually we would come up with the idea that the purpose of pain is protection. Right? It's one of the body's protective mechanisms. And if you've never thought about it that way before, if you think about it, it's like the job of pain is to get you to stop or change your behavior. And that becomes important because the purpose of pain, unfortunately, is not to tell you where the problem is, what the problem is, or how bad it is. The purpose of pain is to get you to stop or change your behavior. It doesn't matter what kind of pain or whether it's acute or chronic, it's always wrapped up in there. So I guess give you another example of when us not thinking about what we think about pain. I'm guessing that all of you have seen a cartoon before, and you've seen a cartoon character drop a cartoon anvil on their cartoon foot, and when they pull their foot out from underneath the anvil, the foot gets really, really big. And to me, this is really fascinating because what the cartoonists were doing was drawing our experience, or a common experience, that if you bang your body really hard, immediately after banging it really hard, there's actually a change in your perception of your physical self. And here, the body feels like it's bigger than before. And of course, we just have that experience. We don't really think about it. But if you do think about this, then you can start to think about, well, I wonder why. Why is it that my foot would feel so big? It would feel like it's bigger. And so our guess is that, well, if your foot feels like it's bigger, you're going to keep it safer. You're going to keep it away from things. So imagine walking through a doorway. If your foot feels like it's 2 or 3 times as big as normal, you're going to keep it further away from banging on the edge. So that's sort of a protection mechanism thing. And so, again, the idea to come back to is that when we are doing contemplative practices, one of the things that we can be guided to do is during the contemplative practices is to watch the pain, or notice what happens with our pain, or notice what happens with our ability to move with ease. And as we do that, we're learning that this pain is actually changing more than we probably thought, and that there's more ways that can change it than we probably thought of before. So I stalled there a little bit because I said pain is a thing, and it's one of the really interesting things interesting ideas for us to consider is that we have, most of the time when we talk about pain, we talk about it as a noun, and a lot of my brilliant colleagues would say, pain is a verb, it's a process, it's a human experience, and we need to think of it more like that than this thing like a table or a chair or a pen or something like that. All right, so in terms of some of the misconceptions that we have, if you were there for the panel discussion, we talked about some of these. The first thing that I would point out, or the thing that I think, the idea that I think most people really have around pain is that it's not really changeable. When we have pain, and especially when it's intense, it feels like it's there all the time. And often what we find is that when we start to do contemplative practices, we notice that it's changing, that it changes by itself sometimes, or we notice that when we breathe in a certain way, or we think in a certain way, or we move in a certain way, that all of these things can actually have some influence on the pain. And so I think this is a key thing because, a key idea for us to understand is that pain is something that we do have some influence over. I hesitate to say that we should be thinking that pain is something that we can change, because often when the word change sounds like on-off, like it's if you can change it, you can stop it. And as yet, I've never met someone who can actually make their pain stop. But I've met a whole lot of people who've learned how to turn it down and turn it down and turn it down and keep on influencing it over and over and over again, more and more and more. I think actually Steve had mentioned a little bit about that. Steve Haynes had mentioned a little bit about the idea that there's a lot of different things we can put together to get the pain to change more. But I wanted to give you a bit of an example of this, a bit of an experience around this that doesn't specifically have to do with pain, but it has to do with physiology. So I'm just going to stop sharing this for just a moment. What I'd like you to do is to imagine that you have a lemon in your hand. So whatever your dominant hand is, or whatever hand is free, just imagine that there's a lemon sitting there in your hand. Your hand can be resting in your lap. But you can feel the weight of the lemon in your hand. And you can feel that it's cold. And you can feel that it's damp. And it's a really nice, fresh lemon, so much so that you can even smell it. From down there in your hand, you can smell the lemon a little bit. So now what I'd like you to do is just to take your hand up to your nose with the lemon and smell the lemon. Right? And then put the lemon back down. So you can get that lemon smell. Now, what you're going to do now is you're going to take that lemon and you're going to put it down on the table in front of you. You're going to hold it with one of your hands, and with your other hand, you'll pick up a knife, and you're going to cut the lemon in two, just with one sort of stroke or sort of shk. When you do that, you cut the lemon, and then you pick up half the lemon in your hand. Now, it's some of the juices have sprayed up in the air, so you can actually smell the lemon even more now. But now you're going to take that lemon in your hand. You can feel the cold lemon juice running down your hand. You can smell it even more. You can take it back up to your nose again and have a really good smell. And now what I want you to do is open your mouth really wide and put the lemon inside your mouth and take a bite. And then you can stop all that and stop pretending that there's lemon there. Now, I did that pretty quickly, but if you're like a lot of people, doing something like that, which took less than a minute, you can actually start to feel your physiology change. It's sort of too bad that I can't see everybody as doing this, because a lot of times when I do this face-to-face, even just the first smelling of the lemon, you can see people's faces starting to squish up. But if you're doing that and it changed your physiology, if you started to feel that you were salivating more, or if you started to feel like your muscles were starting to pinch up together, that means what you were thinking was actually changing the physiology of your body. And so we can sit and have that experience, but then if we think back to pain, the idea is that, well, pain has to do with physiology. And a lot of times, so physiology is the functioning of our body, functioning of us. Sorry, when I say body, I don't just mean without the head, I mean all of you. So your physiology is that what we think can be changed with, what we think can change the physiology of our body. So if thinking about the lemon changed your physiology, you can imagine that thinking about the pain in a different way has the potential to actually be able to change the pain, because pain is, in part, a physiological process. I'm hoping that makes a bit of sense. But sometimes what we need to do is we need to think of, are there other experiences in life that I've had in which I've actually experienced that I could on purpose influence my physiology. Sometimes you do it through looking at visual illusions, where you see the illusion one way, but then with a little bit of work, you realize you can see it in another way. And so if you're doing that, once again, you're changing a physiological process, this time a neurophysiological process. But it's one of those things that to try to get to try to look for the experiences you've had in life that can show you do have some influence over your physiology. Pain is part of that. So let's try to